let me just first start off by saying that I think all of us at some point had thought things would be different, but here we are at things that are, if not more important, they have certainly have had heightened interest, especially as it relates to evidence and information. And I'll argue as we go forward that we are amidst probably one of the greater infodemics we've ever had. And it's problematic. So I've learned a lot from this experience as well. But again, it's an honor to be able to chat with you, and I appreciate all of you who have stuck around to the end of the day to do so. It was initially just think big, but really it's probably in the last 12 weeks, if anything else, it's been more about thinking bigger. And I think I'd start off with this statement, and I think this probably applies to all of us. If we want to have greater impact faster, we have to slow down enough to reflect on where what we've done and what we are going to do. And I think in some cases, for many of us, this has been a forced slowdown. And you've either been proactive or you've been paralyzed. And I think if you've taken the moment to look at what's happening to us as being much more proactive, you can reflect. I can tell you, I've sat down a lot, read a lot. I've just been thinking a lot around what it is that matters. When I look back, I cannot believe it's been 25 years, but it has. And maybe 26 by now, probably around 25, 26 years. And these are the kind of things that I put in blue that I've been, spent a lot of time on. I would have to say, though, that the last 12 weeks have been much more about creativity than anything else. And I don't mean it in the literal sense, a lot more in the metaphorical sense. Now, there's things we can talk about if there's time afterwards, but the principle here is we're going to have to find creative solutions. And I start with this, and this was actually the quote we put up and became the focus of our own McMaster Orthopaedic Academic Day in 2019, where we talked literally about this as the fundamental movement towards thinking bigger, whether it's in your clinical practice, your research, or your leadership aspirations. But creativity is inventing, it's experimenting, it's growing, it's taking risks, it's breaking rules, it's making mistakes. And at the end of the day, it's not for everyone. So not everyone is going to be good at everything. And we've got to decide what it is that you feel passionate about and move in that direction. 1990 was the year that Professor Gordon Guide at McMaster University decided to change the paradigm of research, or the way they educated, trainees, as this new entity that they called evidence-based medicine. Now, you can argue about the pioneers of EBM, but the popularization of the word EBM really started around 1990, and they framed it as an attitude of enlightened skepticism. Fast forward now to 2000 or so, we had our very first attempt at saying, let's bring people together and try to do a textbook called Evidence-Based Orthopaedic. So BMJ and Wiley would say, yeah, great, great, great. Everyone at that time had told me, Mo, it's going to be a very small book. There's no evidence, and these are the non-surgeon colleagues who were saying, this is not cardiology, this is not, oncology, this is not rheumatology. You're not going to find enough RCT data or whatever quality data you want to drive this. As it turns out, it ended up being a very, very large book and a large textbook. And here we are on the months before we're on the second edition, which we are pushing forward. I'll make sure I pass this along to you once we have the information. But we've seen a dramatic growth in evidence. And here's the point, right? I mean, all of us at every level, whether you're a student listening in or whether you're a senior consultant who has been doing orthopedics and leading for decades, when the situation is uncertain, human instinct and basic management training can cause leaders at every level, out of fear of taking the wrong steps and unnecessarily making people anxious, to delay action and to downplay the threat until the situation becomes clear. But behaving in this manner means failing the coronavirus, in this case, the coronavirus leadership test. I put forth any crisis leadership test, because by the time the dimensions of the threat are clear, you're badly behind in trying to control the crisis. We've seen this happening time and time again, and you can reflect a little bit on what it would take and what it's going to take for us to continue to move through this. This is one paper that I did not think I'd be writing in February, and by mid-March, I had a conversation with Mark Swiatkowski. It was on a Sunday evening, and I said, we're going to see a big problem coming up. and this problem's going to happen. And this was in late March, just after, the WHO had called, I think March 11th, they had labeled coronavirus a global pandemic. He said, how quickly can you review these articles? I said, I'll put a team of people on it. We'll get it done. We'll get it to you in 5 days. But if we get it to you in 5 days, you've got to get it published in 5 days, roughly like that. Turns out we dropped it off to him roughly on a Friday, and by I think the following Thursday, it had been published in the JBJS as one of the groups. Now, we actually may have contributed to noise, but let me just share with you what we learned. And this gets back to why we have to think bigger. 1,741 papers, peer-reviewed papers, were published in 59 countries in 447 unique journals. Now, keep this in mind. All of this happened, and I hope you can see my cursor here, between end of January and early April. That basically means February and March, about 9 weeks. There were that many papers published. And also keep in mind, these weren't papers that were in queue from 6 months ago, because coronavirus wasn't known to the world 6 months ago prior to that. The majority of this happened during that period of time. So they were submitted and or published. For those of you who are listening in, who have published or attempted to publish, average time for some of us, if we're really lucky, is going to be, maybe you'll get lucky on the first 3 or 4 months, maybe you'll get a galley in the next 3 months, and maybe you'll see it in print maybe 6 months afterwards, about a year and a half by the time something you get done. Papers are getting submitted and published either on the day of or on average within 10 days. Now, that's a recipe for disaster. This was, so this came out early in, at the mid-April, I think is when we got this published. And look at the number of commentaries being published. There was expert opinion. Journals were pivoting to blue. Lots of opinion, lots of opinion. You can argue that makes sense. But I said, you know what? It's not happening in New England. It's not going to be, it's going to be happening in, in probably the lesser impact journals. In fact, the top 5 medical journals were purporting greater commentaries and expert opinion than any of the impact factor less than 40 journals. So we were seeing a great deal of pressure for journals to be promoting information as fast as they possibly could. And by the way, you're not going to be able to pull stuff out very fast and get data out. So you're going to get opinion. Now, the data you're going to get is going to be what's called rapid machine learning kind of stuff, and lots of interesting things around, well, we can get data collated. And this is a real challenge. Now, having done that, here we are, June 4th. I suspect many of you may have heard, 2 very elite medical journals retracted 2 papers. And so the New England Journal of Medicine and the Lancet both retracted papers. Both papers were observational data sets and had been rapidly collected. Won't go into the details of why and what happened, but here's the point. The rapidity of what was happening was so quick that we were moving well beyond what we would consider standard quality constraints. People are getting funded who shouldn't be funded. Papers are getting published that shouldn't be published, or would certainly have come under greater scrutiny. And if you look at this graphic I put together, which is kind of an example of what I think is a reasonable approach, that second wave is probably what we're talking about, high fidelity, right? However you want to consider high fidelity. I tend to look at high fidelity for a treatment as being something which is controlled and prospective. However, I like the trial, but it can be other controlled and prospective studies. That data is not going to come available to us for some time. If you do it well, it's going to take a lot of time. By the way, there are about 600 randomized clinical trials currently registered, currently ongoing in clinicaltrials.gov. So that data is going to start coming out. That first wave, though, is the wave of everything else. The low fidelity opinions, the commentaries, the rapid papers that are probably rushed a bit and probably leading to more misinformation than anything else. And then there's that small little bit below that red line of high fidelity opinion. And you can argue whether that's coming from the WHO, your trusted colleagues, large associations, et cetera, et cetera. We tried at OrthoEvidence, it's something I've been working on for some years now. We tried to say, okay, listen, in the early phase, while we're waiting for data, let's get high fidelity insights from people that we trust and people we know in our own community who are likely not to sugarcoat things. And that's what we tried to do. But we were still very, very nervous that there's going to be misinformation propagated. And our group was definitely very, very concerned about trying to focus on data, because at the end of the day, we're trying to get to signal. That's it. We're trying to get the signal. And in no other time in history, I can recall, at least in my career, that we've had this much noise in the system. And the noise continues and continues to propagate. Now, I started my career decades ago with one perception that if we were going to tell stories, at least if our group was, and I'm not here to argue that the trial is the best, and I hope that doesn't come across as the only imperative. I'm just sharing with you a personal story of, for me, it was the randomized clinical trial, and it's hard to do lots of things well. And so we said, let's just really focus our career and our group's efforts on clinical trials and collaborative studies. So we had argued at that time, a lot of this, came from the evidence-based model that at the end of the day, if we're looking for a treatment or a therapy, a trial is helpful. I'll also argue to you there have been many, many trials that have been wrong and problematic, and they don't always answer all the questions we want, and maybe they're just not feasible. But for the type of questions we were asking, we thought we were going to own the evidence, because if we didn't own the evidence, we couldn't tell the story. How many times have we been in a situation in our field in orthopedics where a third party has looked at data that has influenced the care of patients in our own institutions, and then we say, you know what, we should collect the data? Why is some third party telling our story? And that's been the message I've been saying for decades, which is we have to work together. And I can tell you, people come together for large programs when they believe it. This is just a sampling of the journey from 1998, which was our very first tibial fracture trial. I was very, very interested in hearing some of the debate. I came on a bit early, and I was watching with great interest, the debates that have been happening on the humerus and debates that have been happening on the tibia, because in some weird and small way, that sprint trial of reamed and non-reamed tibial nailing had an influence. Now, I would think the influence had nothing to do actually with reamed or unreamed tibial nailing, but had more to do with the psychology of what, and you can't see it, a trial of 1,000 patients on tibial nailing. That hadn't been done. And by the way, that was the first big collaborative trial in North America around orthopedic trauma that led to a ton of other big trials. And I think many of you are aware of the METRIC program and many other programs that are going on in shock trauma under George Slobodin, and some other groups there have been doing a ton of big trials as well in terms of the PREPIT program that I end with here. But the point of the matter is, questions can be answered. And at the end of the day, our field has this perception that we can't get our work into the interest of the larger community. Now, there's nothing great, and I'll put it forth, there's nothing great about being published in the New England Journal of Lancet over the Journal of Bone and Joint Surgery or the Journal of Trauma or the Journal of Orthopedic Trauma. There isn't. The only thing is who is reading those journals. If you want to get your message out to groups of people beyond orthopedics, and you want to get that message that say, listen, orthopedics in the greater good of all issues in medicine and in surgery has its place, then we have to work together for some questions that we think impact more than just the orthopedic surgeons. If you look at the topics here, you can see this. These are issues of hip fractures that we all know, right, that aren't just an orthopedic surgeon's issue. It's primarily an issue for us, but it's not the only issue, right? There's lots and lots of issues that we can do and questions we can ask that can lead to bigger and better opportunities for all of us and get people more engaged. But aren't we in that situation now in terms of evidence and making better decisions? Probably no more important have I felt this need to make better decisions in the last probably 12 weeks. And people say, well, decision-making is important, but you have to have a certain degree of skill. If you're early in your career, skill is important. Absolutely. You can't be unskilled in making great decisions, but you have to be at a point where if you get to a point of skill and competence, does spending a lifetime on just skill and competence make you better in your career? And probably the argument would be no, because at the end of the day, decisions are really, really important, and sound clinical judgment is going to be absolutely essential, right? I don't think there's anyone here that would argue this, right? That a poor decision, beautifully executed by the most expert of surgeon, will result in a good outcome. It just won't. So we're going to have to think about, okay, we get to a point of experience and we get a clinical expertise. How do we maximize that? How do we go forward? And I'm here to argue that good decisions come with good data. And experts while extremely, extremely important, as your expertise gives you context and gives you biological rationale, alone will not be enough. And when you look at the outside of medicine, experts have actually a very low level of respectability in other areas because it's perceived that they're often looking at the last history and saying, well, history tells us, but they're not inventing the future per se. That's how it's looked at in other areas. But I argue that when you are an expert and you integrate that with, quote, information and data, you can tell the future. You can absolutely tell the future, and you can make sure that any decisions you make are informed. Now, here's the challenge. Most of us graduate, you do 1, 2, maybe in Canada, unfortunately, we've had a situation where we have trainees now graduating and doing 2 to 4 years of subspecialty training, largely because there's an issue with backlog of positions and resource. However, most of us are thinking that we should do some additional training if we want to become an expert in some area. But then we come back to our institution and we say, okay, you know what? I think I'll just start doing research. I think I'll do randomized trials. I think I'll do this, I'll do that. And we're actually told that we should be doing this and we should be doing more research. But then you're competing at the NIH, at my case, at the Canadian Institute of Health Research, with individuals who are career researchers. It's a very different ballgame now than it used to be in the past. And if you're not going to necessarily say, well, listen, I'm not here to, become a surgeon scientist, but I'll tell you one thing, I want to make sure that I'm aware of the best available evidence. It used to be, and I'm of that era, where our journal clubs as a resident, we'll look at one journal, the JBJS, and we'll look at the table of contents, and we will do that as our journal club. If we were to simply do that in 2020, we would be missing 90% on average of the best available evidence each month. So, just looking at what when we look at individual journals, it's impossible now for all of us to keep up with the best available evidence. Just impossible unless you have a pre-filtered source. So for me, and I put ortho evidence here only because I created it for me, because people would always ask me, what do you read? How do you keep up with everything? And initially it was, well, I tried Cochrane, and Cochrane doesn't really help you in day-to-day decision-making. Or PubMed. PubMed's a research tool. It's not necessarily a tool you're keeping up with best available evidence. So, and you're not going to subscribe to 40 journals. So what are you going to do? So in medicine, they have something called UpToDate, or they have Dynamed. They have pre-appraised resources. So, well, why don't we have that in orthopedics? So that was the reason we did this, and that's the only reason we keep it up. But the one thing I've learned from probably 7,000 RCTs that we put in our database, and probably a handful that we've done ourselves, that the risk of going small is very, very big, and probably bigger now than ever. This individual may be known to some of you and probably unknown to most of you, but he has a very provocative title in terms of what he says. John Ioannidis is a professor of biostatistics at Stanford, and probably has spent his whole career being skeptical of research. He's a researcher by trade, but he's skeptical. And he says, majority of research published findings are false. And if you read this paper, you can sort of say, okay, I can see his argument. You can probably agree to disagree in many things, but he has 3 central hypotheses. One is hot topics are dangerous. If you have a hot topic situation, people clamor at that topic, and so that topic is going to have a quicker pathway to get through some of the barriers that typically wouldn't happen if it wasn't a hot topic. So you can imagine the last 12 weeks, if you were to attach the word COVID to anything, you would probably have a much better chance than not having the word COVID in your title. That may have passed, but we have seen that. I mean, there was an information epidemic on that term alone. Conflicts of interest, are well known to all of us, and that's been a challenge in generally in research. And he also has a central hypothesis: small studies. Small studies are, he doesn't say dangerous, but he says highly problematic. Now, let me explain to you how we get to that point. Let me take it back to that very first sprint trial. And at the time when I read his paper, this is probably a decade ago, I thought, what's he talking about? Like, that doesn't make sense to me. Because if a small study is done really well, it's powered appropriately, you're going to find the answer, right? Whether it's 200 patients, 50 patients, or in some cases, 2,000 or 10,000, all work. That was my thinking as well. Now, we went back and we looked at the tibial shaft fracture study, and we looked at, okay, well, what if we had actually stopped when most studies stop? And by the way, the average surgical trial, and I suspect that I've said this before when I was at Temple some years ago, but I'm positive, in fact, I've said this, that the average size of a study is probably under 100. Let me just tell you all that I've looked at it, that number again, it's a roughly 100. So it hasn't changed in a decade or so. It just hasn't. But let's say we had stopped that study at roughly at 100 patients. Now, if you look at that graphic right there, I think everyone looking at this would say, okay, well, that was the result. It suggested that ream nails were, unream nails were favored with respect to reoperation rates at 1 year. And it had this very wide confidence interval. And I won't go into an epidemiology statement here, but the bottom line with the confidence interval is that the truth could be somewhere between there and there 95% of the time. Now, nobody, I think, logically would say that the truth, if we had more patients, because that's what we say in the discussion, we're slightly underpowered, there's a strong trend towards non-ream nailed, and therefore, if we just had more patients, we had more study power, we would likely show this. That's the truth, but the confidence interval would get narrower and narrower and narrower. But actually, we did recruit more patients, right? So went more and more and more. And what we found was the truth was on the absolute extreme of that confidence interval. So the first thing that made me scratch my head was, wow, that confidence interval is really important. I mean, it's not as some benign little thing that we look at. So when we say, look at the confidence interval in a small study and look at extremes of that confidence interval and say to yourself, if the truth really was on that side, would that change my practice, the way I think about this problem? And if it wouldn't, great, then you stick with your thing. But if it would change your practice, the study's not big enough or the study's not precise enough. So we started finding, oh my gosh, like we're having some real issues. But then I thought, well, you know what, that's a one-off. It's not going to happen again. We did a 100-patient pilot trial called FLOW, which is fluid lavage of open wounds. And that was another big several $million, but it's a big study in about 2,500 patients or so around the world. And we had found this, soap is better. Soap is better, and low pressure may be good too, but soap is better. At that time, I had a ton of people who were a part of our that pilot group and said, why are you spending more time? We have the answer. Go and start promoting this. Go to companies, tell them to start creating a soap dispenser, and let's get out there. And this is an innovation. Let's do this. And in fact, everything made sense because the basic science suggested soap worked better in the lab. And our pilot suggested soap worked better. So great, done. 100 patients, right? Average trial, we're done. I was kind of freaked out by what had happened with Sprint. At that time, I said, nah, you know what? Let's just kind of push this. Let's just say that we're unsure. Let's promote this and let's try to get funding. As it turned out, other agencies saw it the way we saw it, which was let's be sure before you enact something. Well, here we are. 1,500 patients into the study, we realized soap was not helpful. It was harmful. The opposite, complete opposite. And it was so much of a shock to me that I went, at the time that we unblinded, I went to our statistician personally and said, are you absolutely sure A and B are correct? Are you sure we didn't get it wrong and that soap is actually, because I was so convinced that soap should be the winner, and it wasn't. And this led me to a colleague of mine who is a cardiovascular researcher, but a cardiologist by training, who said, Mo, these are predictable. These are very predictable. There's a concept that we call fragility. And you may have heard of this term because it's been out now for a bit, but we have been very, very careful. And he goes, let me walk you through an example. And he walked me through a cardiology example. I said, okay, let me find an example that might be similar at that time that, that might relate to what's happening in orthopedic. So this was an example that some of you may remember was an OP1, a BMP2 study. So this was looking at BMP2 for the treatment of open fractures. And what basically they found was that the use of BMP2 with respect to fractures reduced the risk by 59% of having a reoperation. I think it was at a year. And you see 12 patients had a reoperation in the BMP group versus a control group that had 29 reoperations, and they had a p-value of 0.02. Okay, fair enough. What Dr. Devereaux had told me, he says, don't worry about the p-value. Don't even worry about the total number of patients. Look at the total number of outcomes. Add them up, 41. Okay, great, 41 patients. He goes, if you have a small number of outcome events, you can bet on any outcome that is somewhat subjective, even though you have independent groups evaluating outcomes, that it could in fact risk being flipped very quickly. He goes, let me give you an example. Okay, so that's the study. Now, if we did this study, so imagine this group here, there's about 130 some odd people listening, and let's say everyone decides, okay, we're gonna do the study. And let's say we get a study that comes out and says, okay, 15 patients versus 26. It's still in favor. Just 3 outcome events went from one side to the other. As it turns out, it's a non-significant study now, completely non-significant. So just by chance alone, if that had been their first finding, we wouldn't have heard much at all about, BMP. And, and I remember that OTA meeting where there was so much fanfare about that study finding and all of the things that went along with it. And, and BMP did very well thereafter. And for open fractures, people were talking about it. But there was this quiet discomfort among some docs who were saying, I'm not seeing that. I'm not getting that. Good on the company to say, you know what, let's repeat the study. So they repeated the study. And in March 2011, they actually found, same thing, about 44 events, but this time there was no difference. Now you can argue they had done some changes to their overall methodology a little bit, but principally speaking, same sample size, tibial nailing, and then they found, in fact, in this case, it didn't necessarily help at all. So then we said, oh, wow, that, there you go. That's a fragile p-value. It's a pretty small number, few outcome events. It flipped it and went to negative. And then we haven't really heard too much about the use of BMP in open fractures ever since. Doesn't just happen to orthopedics. So not that long ago, in the highest impact surgical journal, Annals of Surgery, another study, irrespective of the topic, this stuff is going to be believed because it's published in high impact journals. So they look at this control versus treatment, 66% reduction in bleeding events using this one particular approach, only 15 events and a p-value of 0.04. Now, you all don't need me to tell you, but it's not going to take a lot of events if this study was repeated to flip that p-value. And in fact, if they repeat this study in just one outcome event goes from the treatment side to the control, it's a negative study. That's how fragile this particular study is. And by the way, there's example after example after example. So we have to be very, very careful that when we talk about small studies having strong positive effects, that yeah, it's possible that the effect is so obvious and so strong that it is a true effect. But we also have to have the hypothesis that what if it's an error? What if it isn't a strong effect? And I can tell you the number of big trials we've done, every single time I've had a hypothesis thinking it's going to work, it's never worked the way I've thought. And I've had to start trusting in the fact that, okay, I hope we didn't screw up the trial, or we didn't do this. I can't believe we got this wrong. But then I started believing, no, maybe we've had it wrong all before. And it's because we're doing these large collaborative programs that we're starting to uncover where we may have been wrong. But it takes a globe now, right, to answer a research question. These are pictures I've taken out of hotel rooms in the past and traveling, certainly not traveling anymore, and I don't expect to be traveling in the next 6 months. But that being said, our cities look very similar. So if you superimpose top and bottom, our cities look very similar. So the argument of saying, well, we can't do global research, well, I think we can. I think we can actually demonstrate it. But we have to, I think, change the way we think about research. And if we think about research and we think about some of the journals that might say, they're interested in a broader picture, well, if we have questions that are significant, not just for a very limited group of people, but for everyone, or at least at the ideal, research that allows us to get more people engaged, because not all questions are important to all people, but if you get broad enough questions, they're pretty important to many people. And we can grow our team and we ultimately contribute to the well-being. Now, this is now the model I use for research that our group is trying to start. The problem is nothing ever meets all these criteria, but at least we have an ideal by which we are trying to at least consider this as a possibility. So more countries, more centers, more surgeons, more patients. I mean, that's basically where we are. And the thing I've learned is going from ream versus unream tibial nailing. And by the way, ream versus unream tibial nailing was rejected by New England, by Lancet. I mean, it was the quickest cycle of rejections I received at that time, but we were so proud of that work. And it was personally like thinking, why is this not important to you? Why don't you care? And they said, great study design, great collaboration. We applaud all these people for coming together, but we don't see as this being a question of interest to the larger medical community. And they were probably right. I mean, ego aside, they were absolutely right. It was very important. And some might even argue it wasn't an important question even within orthopedics at that time, because they thought, well, you know what, it doesn't really make a difference. If you do it right, it'll be fine. Reamed, you already kind of think reamed works, et cetera, et cetera. But I learned from that, in my case, was the following. Big ideas are by necessity simple ones, and that's it. And so we flipped from ideas like, okay, treatment A versus treatment B. Now, granted, we've been able to get funding for that, but if I rethink that, we've moved from, well, maybe implant is important to a point, but maybe access to care is really important. And that led to this other idea of study in partnership with some of the internal medicine colleagues and cardiology colleagues of a concept that the hip fracture is more like a heart attack. So we called it hip attack, and led to this whole model, recruited 3,000 patients. And this was recently published in The Lancet with some movement towards another study going forward. But the concept was, if you get patients to the operating room quick enough, we may be able to save lives. And that was been the principle. And you can see some of these studies, right? I mean, we're getting numbers because they're simple, fundamental questions that, they're not stem cells, they're not robotics, but they're fundamental questions that do actually matter to probably the majority of people who don't have access to stem cells or robotics, et cetera. But that doesn't mean that non-RCTs should not be valued, because there are situations, and we learned that when we talked about this program called Enormous, which we've just got our 36,000th patient in, was a challenge, because we said, we want to try to understand the decade of road traffic safety as do many other groups. However, we don't even know what trials would make sense in some of these populations, because we don't even know whether the same factors are predictive of early complications in orthopedic care and orthopedic trauma care, specifically across some of these, low middle income countries. So in doing so, we said the first thing to do is a big observational study, and then from that, identify those factors we can truly modify, and then for modifying them, we would then be able to target, essential therapies. So the last little bit here is, it's easy and has been for us to say, oh, that's what we have to do. We have all kinds of great intentions, and I can't remember the number of times, and I look back, and this last 12 weeks has made me look back a lot and think about these things. The number of times that I would have difficulty getting people on board. I'd say, people say, well, you can't do it. It's just not going to work, Mo. There's no way it's not feasible. But if you believe in something, and I'm speaking now to those of you who or maybe earlier in your career, and some of you who aren't, who are still thinking, you know what, people aren't going to buy this. I believe in it, but I don't think I can get other people to believe in it, because they're going to keep telling me it's not feasible. Well, it may be feasible because the individual you're talking to can't perceive how that would work, because they think, well, I couldn't do it, so how are you going to do it? And the only argument to that, and the argument I've used in the past, and I think it works, is, well, yeah, I can't do it, but we can. That's it. And you just built one by one by one. You went from 1 to 2 to investigators, from 2 to 4, and now we're up to several thousand investigators who work with us. And time again, we just build it. And the thing I've learned more importantly is I've had so many colleagues and friends who I've known for many years who have left institutions. So it used to be, well, just, partner with an institution. But institutions don't compete. It's the people in them. And we all know that if you have a handful of people leave your institution, changes the culture, especially if those handful of people are high-performing, hyper performers, as we would call it, by the log tail graph that people talk about in performance. You want to stay friends to them, right? So my always thing is, my loyalty is to people, never to an institution, because people leave. And wherever they go, we will continue to work with them. And it's been this kind of stuff that I think has helped us move forward. These individuals that I've learned to stay around and to keep them in your circles, because these are the people who can anticipate change. They have a pretty diverse network. And more importantly, when you're doing research, you better have the courage to abandon practices that have made you successful in the past. Because if you believe in your study, you truly believe in your study, you've got to also believe in the results. And if those results are different than your perceptions, then you have to really think strongly about how to shift that. We've had, division days where we've brought individuals. You might recognize Mark Swinkowski, you might recognize Tom Einhorn, and that's Robin Richards, who was past president of the Canadian Orthopaedic Association. They were all members of the same traveling year of the AOA a couple of decades ago. And so we invited them all, and they were all reminiscing about that period of time. But they're also reminiscing about now and what it made, and they were reflecting on it. And Tom Einhorn, I'll never forget, said, to me, success is better defined in terms of making a positive impact on the lives of others and achieving happiness and fulfillment in one's own life. Mark Swinkowski had said, well, with 2 solid decades of collaboration across multiple centers, the orthopedic community, and that's something that we should all be proud of, has led the international effort to improve the quality of evidence on which we make treatment decisions. But here's the point, friends. Science is 99% failure, and that's optimistic. These are coming from Nobel laureates who are telling you that, right? And if you're going to ask big questions, well, we're going to have to be ready to fail. And on a personal note, probably every trial that our group has attempted to conduct have succeeded, despite probably a number of times where I thought, oh, this is the time, but we're done. I guess we got to give our money back. This is not going to work. We've had those at every single trial. This is the simple example of a graphic here that shows that trial I showed you that was in the Lancet paper, the FAITH trial. The pink is where we were with recruitment early on, and the blue was this beautiful graph we had sold to NIH and to CIHR, particularly CIHR on this graph, because this is the Canadian enrollment. And I'm looking at that thinking, this is a big trouble for us. And at that point, we said, that's it, we're done. We can't do this, is non-feasible. But what happened in that time of difficulty, people became creative, they became motivated, and the orthopedic community rallied around this particular trial and got it done. But I remember clearly looking back and thinking, man, we had done things differently. We should have made it simpler. We should have absolutely made sure that everyone had the appropriate expertise in the team to pull it off. We had to start with a better infrastructural setup. And at the end of the day, if you're not creative with solutions and you don't have conviction, these things will fail, because that's what it is about. You've got to keep pushing forward despite some of these big challenges. And I'll pause for a second. I've been firing through this, and I'll pause with a final thought. Jack Welch, the late Jack Welch, some people, you may know of him, led General Electric to a very, very impressive gain in terms of their wealth as a company. And he was in many ways called the CEO of the century. And I remember reading an article on him, because I didn't know him, I didn't know much about him, but I liked what he had said at that moment. He said, when they said to him, how did you, how are you such a great leader? And his whole psychology was, it's not me, I'm identifying high potential talent and giving them the freedom to soar. And that's it. He was a talent master. He would just invest in people. And then they said, well, how do you determine who's the person, for the right person for the right job? He says, listen, you can teach people. You can teach people to be execute. You can teach people to even make tough calls. You can educate them on principles, but you can't make someone have passion about what they're doing. You can't make someone be able to energize. You can't have someone who's positive all the time. So that thing you have to find. And if someone shows that, you've got to put him in the direction that allows him or her to be successful. So which one here is the Picasso? I think for most of us, you look at that quickly and say, oh, yeah, I see the Picasso. It's at the end, right? Picasso at the end. It's the obvious. Well, they're all Picasso. And I remember looking at the story of Picasso, and I remember seeing early pictures. I said, wow, I had no idea Picasso was a fine artist, like a true, like a Renaissance level artist. And then you see all these different phases he went through. And ultimately, Picasso found his creativity, what it is that made him famous at that moment, at the latter part of his career. The number of times I have heard senior faculty come to me and say, you know what, we're going to hire a number of new faculty, and and they're going to be the next generation, and they're going to lead research for our program. I always say, why? I mean, great to have them, but they need your mentorship. They need you, and it's never too late to start. So at any phase you're in, it may just be a phase for some, and the best is yet to come. And the great thing for me, I always look at this as saying, no matter where we are in our careers, we can always look forward to change, and that change could ultimately be something that'll lead us to something much greater. So on a personal note, and this truly is the last couple of slides here, this is what I've been doing. I've been trying new things. I've been trying to have fun on the things I really like to do. I'm investing time in that 20%, and I urge all of you to do the same. The 20% of things you do that give you 80% of your life joy, whether it's your life or your work, we tend to negate that. This last 12 weeks has probably got more people thinking about that more than ever. You're going to fail. We're all going to fail to some degree. If we can minimize them, but still learn from them, I think it's important. It's a bit of a cliche, but I do believe it works. And I can tell you, I seek it out in certain areas if I can, because it actually does give you a sense of education. At the end of the day, wherever you are, I'm in my 25th year of doing this, and I still think, well, I can still reinvent myself. And I think all of us could if we really push. So I'll end with this last line. No matter what we do, friends, it's never too late to think bigger. Thank you very much.
I was waiting for Saqib's applause, but I think he...
Oh, it's good. It's okay.
So,
I love that.
That was really exceptional and very provocative. I mean, you know, a lot of us have been thinking about how to do research for years, and sometimes, you know, I've been doing this now approaching 15 years, and I find that
Yeah.
the more that I do research, the more that I publish, the more unimpressed I am with what I've done. And it's an unbelievably humbling process, actually, because in the beginning, you take your rewards from publishing these papers and getting in print, but as you get more seasoned, you realize, what are we publishing? What are we presenting? What's the point of it all? And it's I find that to be quite an arc to actually look back and start to really question what you've been contributing. I mean, I say you, I mean, as a community. So I really connected with that, with what you said, and particularly this concept of these smaller studies and the volume. And you know, I wonder how much of it is driven, and I think Drew Brady brought this up in the discussion, how much of it is driven by the pressure for us to publish something. And every year there's probably a new journal that's out there that we can utilize that also has a need to publish. So that's one part of the problem. And the second is it, we broadly, have we not defined the guardrails or the boundaries or the rules of the publishing and research game better, that we're willing to accept all these smaller studies that we're all guilty of publishing, and muddying the water at times?
Well, let me just first say that before this meeting, I was on a bike ride with one of our mid-career surgeon scientists. So he's an orthopedic surgeon, traumatologist, 5 years into a PhD, and we had a very difficult discussion, you know, and it was really tough because, you know, as much as I want him to succeed, we came to the conclusion it's not his passion. It's very difficult because he said exactly what you've just articulated. You know, but am I a failure now? Because, you know, everyone wants me to write papers, but I don't want to write small papers. And by the way, when I write these small systematic reviews and things like that, they're not getting published. Like they're not, and I'm having more frustrations. I'm spending so much energy in this hamster wheel, so he called it. And he was really like, I probably say this is probably the hardest discussion we've had with this individual for a long time. And I kept thinking, you know, it's different. It's very easy to, I'll use the word virtue signal. But, you know, we should do it all, right? You know, more than any other time, you know, healthcare heroes is the brand. You know, you just got to do it all, and you can't. However, you know, there has to be times where we can still help somebody make an important contribution, and it doesn't have to be what I think you've articulated as the way it's being done. The challenge is, though, his concerns are, well, I'm not going to be able to get promoted now because I'm not writing papers. I'm not going to be able to, you know, climb some of these other things I want to do. And I said, oh, take a break. I want you to take 2 weeks, do nothing. Like you're not going to, I'm not going to let you, I'm going to block everything coming your way. So I don't even try to write anything. You're not going to do it. And I want you to reflect. I want you to come back to me with one simple statement. It sounds cliche. I want you to vision statement in 3 sentences about what it is that matters to you. That's it. Tell me that. And then after that, every single thing you do thereafter, you ask yourself, if you're concerned and you're not sure, look at your statement and say, that's what I want to do. Does this advance one of my core principles and core values about who I am? And if it doesn't, you've got to start saying no. It's hard because this is an individual that loves to be part of everything. And I think we all know individuals, young talent who just wants to do it all. And he's burnt out. He's burnt out within 3 years, well, 5 years now. He's not going to finish his PhD. I mean, it's going to be a very difficult discussion, you know, for him to have with other individuals because there's a sense of feeling let down. But he will look back at this and be happier than he's ever been. And he'll still be a great contributor to our orthopedic community. That's a tough decision.
No, indeed it is. We've been you know, having these discussions in our practice because we're a practice that produces a lot of papers, and I know you're familiar with a lot of them, and how to better allocate our resources in this space. And rather than everybody trying to do some papers, we've tried to move towards identifying kind of our research leaders that will kind of funnel these and concentrate their energies to run larger studies rather than everyone doing smaller studies. So that really hit a chord. I'm going to ask you one last question, and I would encourage others in the audience to ask what they like of you, please, is this concept of fragility and the fragility index. This is the second time I've heard this. Is this something that we can quantify or codify and be another way to, rate a paper's quality? Just like we can rate a journal's impact factor. Is this something every paper can be looked at as a way to grade a paper?
Absolutely. So if the paper has an outcome that is yes or no, or like an infection, mortality and reoperation, a dichotomous outcome, you can measure fragility. In fact, the original paper, and what I'll do is I'll make sure I follow up and get you the reference for it. It's probably now several years old. But they created a table in it that said, if, based on this and this and this, it'll have a fragility number of this, and then you can make a decision, right? Because it's like an effect size. It doesn't have a unit, so you can compare it across any study in any area. But the fundamental point is, what's the number of events that have to flip from A to B to go from a positive to a negative study, or a negative to a positive? And that just tells you, if it's a handful of events, folks, it's fragile. It's probably chance, and if you repeat that study, you're probably not going to get the same answer.
I had Asif asked some great questions that were on my mind, and pulled up one of the questions also from the chat room. So I think we're mostly caught up with that. The one question I had, a little bit of a smaller issue. Do we tend to believe positive studies and more than negative studies? You brought up the BEST trial. And for those who don't remember, this was the trial back in 2002 that basically said that we have a great randomized controlled trial, 400 patients, says we should use BMP2 in open tibia fractures. And I was at the OT. I remember it was a
that, right?
Huge deal. And then when the paper came out in 2011, when that was at the OTA, it was crickets. I was in the room. I was like, where's the line of speakers coming up to ask the questions? Why am I not? I was literally like, why am I not hearing about, like, why is this not a big deal now? This just blew the initial paper out of the water. So I just wonder, do we as clinicians, do we get excited about the positive stuff, and when something's negative, it doesn't register?
Well, I put a caveat to that. So Paul Ternetta, myself had this discussion, and Mike McKee and I just recently had this. We were on a call together recently, about maybe 3 days ago. And I'll frame it this way, and I'm paraphrasing from what others have also we've chatted about, but it matters if it's positive in the direction that fits your personal lens. So for example, if you are someone who makes a living out of surgery, one argument would be that you would like to be able to promote evidence that supports hypotheses around surgery. So when the clavicle fracture went from a negative study, non-operatively treated, hey, surgery can make a big difference. It was almost a tsunami of an exponential curve that had Mike McKee saying, whoa, and then you've got to pull it back. And now we've come back to a pendulum that says, we know when to operate, when not to. It's not like it used to be where nobody gets an operation, but it's also not the other extreme. But there were relative crickets around the issue when we said Achilles tendons that were, going from operative, and more studies came out. Western Ontario and a few other in the Netherlands, people were coming up with studies saying, operative and non-operative Achilles tendon, you can have pretty good results with non-operative. They were getting a lot less airplay in certain areas. Now, flip it around to knee arthritis. One can argue that the guidelines that came out that said injectable treatments don't work, and this is an orthopedic surgical guideline. The perceived bias there was, and that's why there was an outcry from the rheumatology groups and from the sports medicine groups that were saying, well, sure, you want to get rid of everything that impedes getting a total joint replacement. And that was the back and forth. Now, I'm not saying all this is the fact, but the reality is that we all have lenses, and we look at data from our own lens and from how we perceive information. But when we say that a negative study is a problem, for sure it is, because small studies can also be negative. But you can also argue that a small study that's strongly positive should raise the same degree of concern. Not that it's wrong, but hey, if we adopt this, is there a possibility that we're off, right? Is this a possible spurious finding? So chance plays on both sides. It isn't just positive studies are always right and the negative are always wrong, and the negative never get published, right? It's just just have to have some degree of constraint around that. That's all.
Mo, there's a question here from Dr. Shikumbi, who's one of the chiefs of the local orthopedic departments, and there's a lot of medical students, residents, and surgeon educators on this symposium. So the question is, and I think I know what you're going to say, but still, it's good to hear it again and paraphrase. Any words of wisdom for these young researchers on how to be, how to navigate the current dynamics, how to be effective researchers?
Yeah, I mean, you can almost argue that could be a whole lecture set in a series, and I think people have put all kinds of things to it. I think the thing I would say is that surround yourself, if you're a student, it's hard sometimes because you don't know, what the landscape is, but surround yourself with individuals that have already had some degree of success in the area that you're pursuing. So for example, if you are a student looking to get involved in clinical research, it might start off having a better experience if you work with a team of people that actually do clinical research rather than try to start it up. There's lots of examples where things don't always work in that direction. But the key thing is always know that you can apprentice into it. Like there's no reason to jump in and say, I'm going to lead my first project. A randomized trial is probably something that, like when I started off at the level of learning, then jumping in as a site and then going in that way. That is the easiest. The second thing I would say is we truly are in a global system where you can get on a call or on a phone with anybody. So look locally, but think globally. And the number of people that will connect with you and give you advice is almost infinite. And my perception is that when you say, oh, that person's too busy because look at all the things they're doing, the reason that they're doing what they're doing is because they collaborate. It's rare for someone to rise in isolation and in a silo. So they're looking for new people to work with. And that student may become the bridge between someone at that institution and that individual, and they may be able to see that example. So I would just simply say, don't fear failing. Get out there and try. The worst thing you can do is psych yourself out. Just get out there and try and communicate and find people that you feel inspired by, wherever they may be in the world, and don't be limited by your own institution. So many of the things I did at McMaster as a resident were with individuals that were all over the world, because McMaster, while very strong in certain areas, didn't have some of the other areas I was interested in. And I use the same example with anyone else.
I think we should end it on a good note. That was very thought-provoking. There's a lot of things I can say. I think we all learned a lot. I'm getting a lot of private comments and text messages from a lot of the faculty participants and others who are really glad they were here for this part of the meeting. And on the Zoom timestamp, I've been in this meeting now for 9 hours, 45 minutes, actually, from when I opened it. This probably is what the NFL Red Zone guy feels like when he's like calling games all day long. Thank you very much, Mo.